Hi everyone, here is Marián Švajdler and welcome back to our next Bioptická multi-head seminar, and I will show you a couple of quite basic but still interesting cases. The first case is appendectomy, sent in consultation with the question whether this lesion could not represent low-grade appendiceal mucinous neoplasm. And here we can see it's something like cystic dilatation of the appendix with attenuated epithelium of mucinous type. So I think the question is quite good, whether it's not Lamen or low-grade appendiceal mucinous neoplasm, but still. Here you can see there are residues of lamina propria, and if you go, let's say here, you see still crypts well preserved, and there is no real like fibroplasia of the wall. So the anatomical composition of the wall is still retained. And if we go further, it continues into completely normal mucosa of the appendix. So this is not that common, but I would say not very rare situation. And the correct diagnosis is appendiceal diverticulum or diverticular disease of the appendix. So sometimes the epithelium of the diverticulum may be very much attenuated, and even you may have perforation of the diverticulum and spread of the mucin in the wall of the appendix, or even outside the appendix itself. So complicated diverticulum of appendix may be a mimicker of lamina. Okay, so this is kind of biopsy I see from time to time, sent in consultation, and it's the best clue to the diagnosis is to describe diverticulum during the grossing, the appendix. You frequently may see it's a cystic lesion in continuum with the lumen of the appendix, and preservation of crypts and lamina propria around the lesion are the most important clue to the diagnosis. It's not Lamen. My second case is brain biopsy. This is a consult case from Alexandre Carneiro from Brazil. This is a child case. I believe it's 6 or something year old. Lesion in her temporal lobe. And we can see it's a little bit myxoid, obviously a low-grade lesion composed of this roundish, monotonous proliferation of almost oligodendrogloma-like cells with no mitotic figures, no necrosis, no microvascular proliferation. And so the question was obvious what it is beyond diagnosis of low-grade neuroepithelial tumor, and we performed methylation profiling, and it came back as Dysembryoplastic neuroepithelial tumor, or DNET. It's a low-grade lesion in children or very young adults, most frequently occurring in the temporal lobe, and associated with chronic intractable epilepsy, which couldn't be treated by medications. And In this particular case, we cannot see the diagnostic specific glio neuronal component, which is so-called floating neurons within the lesion. So it's quite non-specific picture, and DNET is notorious for very high or let's say low inter-observer correlation, and may mimic other low-grade tumors, including pilocytic astrocytoma and other tumor types. So in cases like these, genetics or molecular or methylation profiling is quite important. This tumor type shows MAP kinase pathway alteration, most frequently FGFR1 gene mutations, but BRAF mutations are also quite common. So DNET is the second case. My next case is quite basic biopsy of endometrium of older lady with this polyp. But in the polyp there is some kind of not that good looking proliferation. And I have already showed you here that you always should look throughout every polyp to rule out some kind of malignancy. Yeah, here bad looking glands, and this could be endometrioid, but still it could be serous as well with glandular formation. So I performed some immunohistochemistry, and this is P16, which was not helpful because it showed this quite widespread and quite strong positivity, maybe not completely diffuse, but almost diffuse, so it wasn't helping. And P53, sorry, it's here, was like this. I would say it's overexpressed, so it's not helpful. Ki67 was diffusely positive, so not very helpful. And unfortunately, I had this antibody. It's ARID1A, and the lesion shows loss of expression, which is very typical of endometrioid endometrial adenocarcinoma. So this mutation, ARID1A gene mutation, occurs in up to 50% of endometrial adenocarcinomas. So loss of immunohistochemical expression is guiding you to that diagnosis. And even if you've got only these, which I would call endometrial intraepithelial neoplasia or AIN, it's not carcinoma yet. This loss of expression will tell you that the probability to having cancer in the future is almost 100%. So all ARID1A deficient lesions are markers of high risk of having endometrioid adenocarcinoma. So AIN with ARID1 loss is this case. And I will skip to some soft tissue pathology. This is a lesion somewhere on the back between scapules in, let's say, middle-aged male. So this hypocellular, little bit myxoid looking lesion. And the clue to the diagnosis are these collagen bundles, right? And myxoid background and location as well. And in addition, we have these mildly hyperchromatic, mildly atypical spindle cells present, and that's it. One important component was completely missing in this lesion, in this particular case. So anybody got any suggestions?
There's no fat.
There is no fat, yeah. Fat is missing. And the lesion was diffusely positive for CD34 with retinoblastoma protein loss in this spindle cell component. So this is our retinoblastoma protein. You can see that it's retained in the vessels and in endothelial cells and lost in the spindle cells. So this is so-called fat-free variant of spindle cell lipoma. So it's not that common, but you should have it in your differential diagnosis when looking at myxoid spindle cell lesion, especially in the upper back region. All right. My next case is a 14-year-old boy with a lesion in his retroperitoneum, and he was initially treated for Wilms tumor. In Europe, we have neoadjuvant therapy and resection after that, but they found that there was no tumor of the kidney, and the tumor was only sitting in the retroperitoneum. And they sent it from Slovakia here because they couldn't make any diagnosis. So we see this spindle cell pleomorphic, highly malignant lesion, which was negative for all immunohistochemical stains we have performed. Anything you can imagine was negative, basically. And we have performed NGS and methylation profiling, and it came back only with P53 gene mutation with allelic frequency about 90-something%. So this is very suggestive of germline mutation. So the patient and his family should be investigated for the presence of Li-Fraumeni syndrome. And my diagnosis is pleomorphic high-grade undifferentiated sarcoma only. So there is no other possibility to do with this case. So this is quite unfortunate case because obviously there is no effective treatment for retroperitoneally based undifferentiated pleomorphic or spindle cell sarcoma at all. Okay, undifferentiated sarcoma in very young child. This is quite uncommon situation, except for he's having germline syndrome with P53 gene mutation. My next case is a tumor of the liver. Again, sending consultation from Slovakia. Yeah. And it's quite interesting. And you can see this highly malignant, again, spindle cell sarcomatose kind of proliferation with many mitotic figures, atypical spindle cells, maybe with some bizarre cells as well. And in addition, there were areas with these tubular formations. These tubules were atypical, showing lots of mitotic figures. With some necrosis, probably it's not osteoid, but it could happen in this kind of tumor. And various types of cytokeratins were positive like this. Was positive in this, let's say, well-differentiated part, this glandular part of the tumor's proliferation, and was completely negative in sarcomatous part. So my diagnosis was hepatic carcinosarcoma with bile ductular component and the differentiated sarcomatous component. The third component, which is quite common in this tumor type, is hepatocytic differentiation. So there may be mixture of hepatocytic bile duct and sarcomatous component. And as always, in this type of tumors, you may have heterologous differentiation in sarcomatous component, including smooth muscle and rhabdomyosarcomatose or chondro or osteosarcomatose or whatever. Okay, so this is my first case ever of this tumor type.
Age? Old? Someone?
It's middle-aged
And
male.
it's a core biopsy.
It's a core needle biopsy, yeah. So small, tiny biopsy. So I cannot really rule out hepatocytic differentiation. It can be there in the resection specimen. So hepatic carcinosarcoma, very, very rare example. There are only tens of cases described in the literature. So another case is from our colleague Romek. He's a very experienced and good pathologist, and he made easily correct diagnosis. This is biopsy from the rectum in, again, middle-aged male. And we can see this quite normal-looking squamous epithelium. And it's infiltrated by something bad-looking. So this clearly high-grade malignant lesion. Let's say smaller cells. So any suggestions here? We should do immunohistochemistry, right? So cytokeratins were negative in the lesional cells. CD45 was negative, and
CD20.
it was negative. It was not performed, but it would be negative, and this is positive immunohistochemical stain for melan A. So the lesion is positive for SOX10 S100 protein, melan A, and others. So this is an example of, let's say, small cell melanoma, and it could be primary there in rectal mucosa, because we may have mucosal melanomas, and rectum is one of the sites where to look if you got metastatic melanoma from unknown primary. Still, it could be metastatic disease from other primary. So the clinicians should decide what is the correct answer to that question. So rectal melanoma. So melanoma is mimicker and may have these monotonous small cell morphology. Remember that, and you may have a primary rectal melanoma. The next case is again, it's older female and she had quite a big, maybe 10 centimeters, big lesion under the skin on her thigh. So big tumor, and it was resected. Grossly, it was quite well circumscribed, and the morphology was quite on the tight. Tight. This pleomorphic malignant cells, some spindle cell proliferation, even maybe something like clear cell, some bizarre cells. And in other parts, almost alveolar soft part sarcoma-like areas with this cohesive pattern of pseudoglandular formations and with little bit rhabdoid-looking cells. And even something more like carcinoma-like pattern, more epithelial. So again, we should perform broad panel of immunohistochemistry, including cytokeratins, right? And although cytokeratins were almost completely negative, there were parts with this strong and immunoexpression. Okay, so is this undifferentiated carcinoma? So always perform your cytokeratins with other markers, because this is SOX10 and S100 protein and other melanoma markers were positive as well. So this is a metastatic malignant melanoma with focal cytokeratin expression. So this is something that you should have in your mind, that melanomas sometimes may express cytokeratins and should not be confused as the differentiated carcinomas, because the mistake is fatal for the patient. Okay, so cytokeratin expressing melanoma. Okay, and my last case is a fine needle biopsy from pancreatic mass. Again, middle-aged female with a tumor in the pancreatic head, I believe. And you can see this Dysembryoplastic stroma infiltrated by clearly malignant looking cells. I have showed this tumor type before here, because it's not that uncommon. In some other regions, you can see a little bit different differentiation with these eosinophilic cells having squamous cell appearance. So this is an example of adenosqamous adenocarcinoma of the pancreas, which is a variant of pancreatic duct adenocarcinoma. Adenosqamous carcinoma, yeah. It's quite common. I see one case every, I don't know, 4 or 5 weeks. So it's not that uncommon. And surprisingly, this is P40. P40 shows this really widespread expression in almost every tumor cells. So it's more squamous in this case than adenoma, but still there are some glandular features. And again, it's a variant of pancreatic duct carcinoma, quite aggressive one.
Můžu, Michal? Okay, Alena Skálová, I have a couple of easy cases from hepatic pathology for you. The first case is čím začneme? Is the tumor of a 69-year man, and the lesion was sent as a consult case as epulis, well circumscribed a little bit, polypose lesion of intraoral mucosa on a maxilla. So the lesion was covered by relatively intact squamous epithelium. There was macroscopically no erosion, no ulceration, and the tumor was hard in consistency. High magnification will show the cells. If we start with the stroma, there is a focal myxoid transformation in the stroma. I'll show you immediately high magnification, and we'll see the cells again. So there is you can see that there is two types of stroma, and I believe this is the most important feature of the tumor, more important than the features of epithelium, which gives the name to the lesion. Here we can see hyalinized stroma, and in other places, like here, you can see I'm looking for the arrow. You did use it. Did you use it? No, not yet. But anyways, I can speak about it. So one type of stroma is this hyalinized, which you can see in the right part of the slide, and there is more cellular. Now it's there. I see. Now it's perfect. Thank you very much. So this is the other type of stroma, and in addition we have this myxoid stroma. And if we look now. If we concentrate on the cells, here you can see quite typical feature, and this is this epithelial component, which is composed of clear cells. So the name of this lesion is a clear cell carcinoma of the oral cavity, and it has it's easy if all the features are present, which is this case. However, it's not always so easy, because you not always have the cells clear. Sometimes the cells may be eosinophilic, but in this case it was quite nicely developed. The features were quite easy.
Clear cell odontogenic carcinoma?
The other that's very correct. There is a comment that clear cell odontogenic carcinoma, but it has the same morphology and same fusion, which I will tell you later. But this odontogenic is inside the bone. This is superficial. This was epulis. This was superficial lesion. Immunoprofile is not so surprising. I do not have immunohistochemical slides here, but it was positive for P40, P63, and for cytokeratins. But we confirmed diagnosis of clear cell Hyalinizing carcinoma by detection of fusion transcript EWR1, CREM1. CREM is an alternative partner for ATF1. The most cases of this tumor do have EWR1 ATF1, but this one was fused with CREM.
Okay, so the diagnosis is clear cell. Now in a new WHO classification, it's again called Hyalinizing clear cell carcinoma of the oral cavity. So that's my first case. My second case is tumor of a maxilla of young woman. She was 32-year-old, and that was a consult case, and I'll have to start somehow. So here we have the surface maxilla, I told you, and there is this tumor infiltration, and of course you can see close proximity of minor salivary gland. And if we use high magnification, there is a very strong and very typical feature which is seen immediately, and that's a type of secretion. I'll use high magnification to show you it's invasive tumor. You can see that the structure is sort of microcystic, and the secretory material is bluish. The discoloration, bluish discoloration, shows you the immediate diagnosis. And I'll tell you exactly. I'll tell you later. But before giving diagnosis to everyone, there is another one very typical feature, and this is pseudoepitheliomatous hyperplasia of the surface, which is also described as one of the features. And you can see that the surface is not infiltrated. There is no erosion. But it's not encapsulated, it's invasive. And if we go down to the bottom of the lesion, there is really invasion, sometimes even perineural invasion, and it can grow deep into the proximity of the bone. So diagnosis is microsecretory adenocarcinoma, and it's a new entity in WHO classification. And for this entity, we really confirmed diagnosis because in addition to quite specific immunoprofile, which is CK7 positive, S100 positive, SOX10 positive, and P63 positive, which is different immunoprofile a little bit from secretory carcinoma mask. This one, the diagnosis is confirmed by fusion transcript MEF2CSS18. That was done in this case. So the diagnosis has been confirmed by molecular testing. But I believe that the morphology is pretty typical with this bluish discoloration of secretory material.
P40 was negative? P40 was negative?
P40 was negative, which is correct. Mammoglobin was negative, which is also correct. And P63 was positive in about 50% of cells. And it's different from mask. Yeah. So microsecretory adenocarcinoma of minor salivary glands.
Just like it can be primary in the skin as well. It was described. We have one case.
Okay, very good. It's a relatively new entity, even in oral cavity. It's a new. Okay, easy case. This is easy, but diagnosis was a lymph node or some kind of resistance in front, pre-auricular location, yeah, in the face, and the lesion is of course related to parotid gland, which we have in the upper part of the field at the moment, and the lesion is here, so it's somehow modified by the extirpation. But I wanted to show you that even if we do not have at this moment we do not know what kind of immunoprofile it has, and we cannot see mixochondriate stroma. It's still you may start to think about pleomorphic adenoma quite easily because of the presence of this material. A couple of years ago, I would say 30, 20, maybe, maybe a longer time, a couple of years, we described presence of deposits of extracellular matrix, which we call collagenous spherules and collagenous crystalloids. And here you can see something like that, collagenous crystalloids, and it's related to secretory activity of myoepithelial cells in myoepitheliomas and also in cellular pleomorphic adenomas. And this was the case. I can show you that it's really pleomorphic adenomas. This is plaque 1. Staining plaque 1 is my favorite because it works quite well. So the staining is in nuclei of all the cells of the lesion, and it's a good surrogate marker, plaque 1 immunohistochemistry. And my last case is horrible. It's a tumor of a nasal cavity of a 69-year-old female patient, and it arrived as a consult case from Slovakia, as Marián said, and we had quite difficult cases from Slovakia sometimes. The tumor is very cellular. It's quite solid. You can see that it's divided, sort of one type of the cells. It's divided by fibrous septa, thin fibrous septa, and the cells are quite monomorphic. I'll try to show you high magnification a little bit more. And well, and I do not have too much to show you, but all the cells were positive for cytokeratin, pancytokeratin. All the cells were positive for P63, completely positive for P40. P40, P63, and all cytokeratins you can imagine. Nasal cavity and this type of infiltration. And surprise, surprise, we did testing and it came back with EWSR131.
Okay.
So it's ALES, Adamantinoma-like Ewing sarcoma. It has been described quite recently. We did not believe that it is Ewing sarcoma. More and more cases, we already have 3 cases in registry at least. Yeah, you pracuješ na jednom, he works on the next one. But it's really probably existing. The question is if we really should call it Ewing sarcoma, if it's so epithelial. At the moment, it has a position of subtype of Ewing sarcoma in a new edition, but it's probably going to be changed. It's quite
probably
possible.
not, because based on methylation profiling, it clusters it as a completely separate entity.
Must cluster separately from Ewing
It's probably
sarcoma.
epithelial kind of lesion.
Exactly. That's exactly what we
exactly
tell.
the same like Ewing, yeah.
But before I leave the position here, I'll show you this immunostain, which I did only after receiving the results from molecular lab, and soft tissue pathologists know it very well, and it's NKX22, which is typical for Ewing sarcoma, so even immunoprofile. And there was CD99 a little bit not so beautiful like this one, but it was also positive. So immunoprofile is in favor also for Ewing sarcoma phenotype or genotype. So that's ALES, Adamantinoma-like Ewing sarcoma of nasal cavity in 69-year-old woman, relatively big tumor. Yeah.
And that's Alice.
That's ALES. ALES.
It's Michael Jr. now. I don't think I'll be able to match the quality of the cases with my set of cases. Generally, some ordinary skin and soft tissue regions. This is an adult person, tumor on the back, and it's mostly quite unremarkable, covered by normal epithelium. It's polypoid lesion, pretty small. So the most striking thing you can see from low power are these myxoid pools, which kind of look like there is nothing else. But if you go on higher power, you can still see some rare, completely bland spindle cells without mitotic activity, and you can also appreciate the separation of basically the collagen fibers, so cleft-like spaces basically, and occasional vessels, which are also quite unremarkable otherwise. So this is quite a textbook case of cutaneous myxoma or cutaneous angiomyxoma. Yeah, if you would have a patient with multiple lesions like this, you could think about Carney syndrome or Carney complex. Carney syndrome. Okay, I never know. Okay, next case was a nuchal area of an adult person, and there was basically just collagen, fat, so nothing really that interesting, but a lot of fibrous tissue, and in one area you could see some kind of like bluish hue, which on a higher power shows signs of some early cartilaginous differentiation. You can see this cartilaginous lacunae, and this bluish color is kind of characteristic for cartilaginous differentiation. So it looks like a kind of like a chondroid metaplasia, and in this nuchal area, this lesion has a name. It's called nuchal fibrocartilaginous pseudotumor. It was first described in 1997, I think, and this is a paper by my father and Dr. Zámečník, published 2 years later, which is the only one I had access to at the moment. So this is the name. So it's a basically pseudoneoplastic lesion, which in basically all cases looks like we've just seen here. It's probably related to some chronic mild stress in the area, and interestingly, there is a very similar or identical lesion described on the foot. It's called myxochondroid metaplasia of the plantar foot, described by Andrew Fulp, and it looks really pretty much identical as we've seen. I had one case 2 years ago. I don't have the slides with me. So again, fibrous tissue with chondroid, completely bland chondroid differentiation. So it looks pretty much similar or identical to what we know from the nuchal area. There should be some similar structure on the foot of horses.
I believe it's more widespread kind of lesion.
Yeah, than this.
I can recall that I frequently see it in various orthopedic excisions next to, let's say, implantations or tendons or whatever. So
I agree.
this kind of chondroid metaplasia is quite common.
Can occur pretty much anywhere, but I guess these two locations are there. It's more common. The chronic trauma is more common there.
Yeah.
So no soft tissue now. This is vaginal polyp. adult female covered by kind of maybe slightly hyperplastic epithelium, but otherwise normal epithelium. And in the stroma you have these multinucleated or floret type cells, some bland spindle cells in the stroma, and vasculature. So this looks like a normal fibroepithelial stroma polyp of the gynecological tract. There is, however, one maybe pitfall. This is Desmond staining. You can see some Desmond staining in these lesions, which is well known. But there is also, if you would be stressed that this might be some botroid rhabdomyosarcoma or something, and you would stain for more specific skeletal muscle markers as MyoD1, you would also find expression, not usually not completely 100% of cells, but some cells will stain with MyoD1, and it's also absolutely normal. Again, described in a small paper by Andrew Fulp, and it's a constant feature of fibroepithelial stroma polyps, MyoD1 expression. So don't get scared. Yeah, fibroepithelial stroma polyp of the vagina. Next case, this was peritoneal lesion. It was described as a carcinomatosis of the peritoneum, some older person. So you can see we had two samples from this patient. One is shown here. This is very hard to diagnose. It definitely looks like a malignant proliferation. It's atypical round or epithelioid cells. Some reactive stromal changes. So from the sample here, there is definitely something bad happening, but we don't know really what it is. So you should start with immunohistochemistry. Definitely first is cytokeratins, which were negative. Before you start with immunohistochemistry, it's definitely a good idea to continue with morphology if you have more blocks. We luckily had this other sample from different nodule, and here it looks much more like a helpful clue. So there's again some ugly atypical spindle or epithelioid cells, but there is also a lot of this sclerotic stroma. Any ideas or suggestions what this could be? It's negative for cytokeratins, I can tell you that. So we definitely should continue with the major markers, S100, SOX10, HNB45, mesothelial markers. Everything was negative.
For
Yes, exactly. Given this sclerosing morphology, with spindle to epithelioid cells which are clearly atypical malignant. Look here. It's a good idea to think about, and given the immunophenotype, because it's not the first thing you would think about on the peritoneum, but given the morphology, it's a good idea to add MUC4, and this is MUC4. So this is sclerosing epithelioid fibrosarcoma. High-grade sarcoma, which typically occurs in deep soft tissues, but some 20% or maybe 1/4 of cases can occur in abdominal cavity, deep visceral soft tissue, deep visceral locations. And I've seen multiple cases in abdominal cavity presenting often like carcinomatosis. So this is a good lesion to have in mind when all immunomarkers fail and you still see a malignant tumor. So next case, this was an inguinal soft tissue adult person. Do I have time? Okay, 10 more minutes. Okay, so we start on low power, which we with soft tissue lesions, you should always start with low power. I don't do it here much because in the microscope it doesn't look that nice, but on the screen looks okay. So I'll start using it more here. So it's a very, very well circumscribed and also encapsulated lesion, and there's fat around it. And if you go on low power, higher power, you can see quite cellular proliferation, again bland, pretty bland spindle cells. It was very low mitotic activity. I don't recall if I found them 1 or 2 mitosis or 0, just low mitotic activity. And this kind of has storiform arrangement, which might make you think of dermatofibrosarcoma protuberans, which would be definitely a good differential. But one thing doesn't fit here, and that's the good circumscription. Of course, there are these new PDGFD rearranged DFSPs, which can be circumscribed like this. And indeed, CD34 was diffusely positive, so this would still be suggestive of DFSP. But CD34 is also a good marker of perineural differentiation. And if you add other markers of perineural differentiation, this is claudin 1. There's diffuse positivity, perfect, basically. It's probably the best claudin 1 staining I've ever seen. It rarely gets so diffuse. So one marker is diffusely positive, another marker is GLUD1. It's the least specific, but the most sensitive, again, diffuse GLUD1 positivity. And the most widely used, but perhaps most problematic marker is EMA, which is quite sensitive for perineural differentiation, but you have to be careful with it because it's often very weakly positive. So you gotta go on high power and check it carefully. And this is actually pretty good for EMA in perineurioma. It's pretty diffuse, it's very weak, but it's diffuse. And in combination with CD34, claudin 1 and GLUD1, and of course with the morphology, this is very strong support for the diagnosis of perineurioma of soft tissues. So it's a well-known soft tissue tumor, but actually a pretty rare one. You don't see it that often. So another case is a 61-year-old male, tumor on the thumb. Another benign soft tissue lesion, very unremarkable. On low power, just collagenous tissue. A little bit multilobulated. If you go on higher power, you again start seeing actually some cells here. Very bland, ovoid spindled cells. In some areas it's really hard to actually see any. But in areas like this, you can also see a little bit more spindled or ovoid cells. And I say it pretty often and show these cases pretty often here because they are not that rare. This is desmoplastic fibroblastoma, or collagenous fibroma is another name. And the morphology here is best described, as my father suggested, as a spermiogram of infertile male. So these rare spindled cells, you can imagine them like rare spermia in the spermiogram. I didn't know how it looks, but I looked it up on the internet, and really, this is a very good mimicry. You can see the little tails of the spermia here. So I think this is a very helpful clue. So desmoplastic fibroblastoma, completely benign soft tissue tumor.
Everybody learns it then, yeah? Everybody recognizes it then. Yeah?
Okay, one of two more cases. This is a tumor on the finger, 55-year-old lady. You see a skin excision, part of the underlying bone, and this unencapsulated but kind of a little bit partially circumscribed tumor, which on higher power start looking a little bit scary because they have these hyperchromatic atypical nuclei. But in some areas it looks familiar.
Glomus.
Yes, this looks like a glomus tumor, glomus cells. These in the center. Maybe I'll be able to find. Okay, here is the arrow. So these are perfectly round cells where you can see the cell membrane basically. Or here. So these are good examples of glomus cells. And what about these ugly hyperchromatic cells? Does it mean this is malignant glomus tumor? There are malignant glomus tumors, of course, but there is a spectrum going from benign to malignant, and then in between there are also atypical glomus tumors. You have some criteria based on mitosis, I think size and necrosis and stuff like this. Spindling. So you have to, or at least I have to look it up anytime I see it in the book. But there is also a variant of a benign glomus tumor which is called symplastic glomus tumor, which shows exactly these hyperchromatic glomus cells. The crucial feature to call this symplastic is basically a lack of mitotic activity. There was not a single mitosis in this whole region. So this is best described as symplastic glomus tumor. Always suggest to add that it's completely benign because of course the clinicians have never heard about it. It's pretty rare. Otherwise you see all the features of glomus tumor, this myxoid stroma in the myxoid background. And also we had this very helpful clinical information that it was very, very painful lesion clinically.
There's one clue to diagnosis of malignant versus benign. If you are not sure, you can perform copy number variation analysis because benign ones have completely flat curve, no copy number changes, whereas malignant cases show like more complex copy number variation plots.
Yeah, that's also helpful. It's kind of helpful in most soft tissue tumors. If there are no copy number changes, it's much less likely to be malignant tumor. In glomus tumor, very helpful feature is also if it's on the fingers, it's very, very likely benign because there are on the fingers, glomus tumors are very rarely malignant. If it's in deep soft tissues in visceral locations, there is much greater likelihood it will be malignant, especially if it's like in the esophagus. Esophageal glomus tumors are almost always malignant. Glomus tumors in the stomach, there it's much more variable. Some can be benign. Just back to the case, this is smooth muscle actin. It should be diffusely positive. This is a quite, it's like 5 years old case, so it's a little bit faint, the staining, but you can see it's positive. Also useful, it's not specific, but it's still useful. Collagen 4 should kind of paint the intercellular spaces or the cell membrane basically. Very last case, just to remind you again, finger, adult person. This is ordinary glomus tumor, myxoid variant. Again, smooth muscle actin diffusely positive, collagen 4 diffusely positive. Okay, so this is all from my side. Thanks for watching and see you next week.